Hello friends, I am Ankita Tiwari, research scholar pursuing my PhD from Department of Pharmaceutical Sciences, Dr. H.S. Gaur University, Sagar. Here, I am going to present another interesting and learning episode of B.Pharm 6th semester entitled as Totally Synthetic Analgesics 2, which is scripted by Dr. R.L. Tiwari, ex-Senior Scientific Officer FSL, and Sandeep Srivastav, Assistant Professor, VIth Pharmacy College, Sagar. So, we will start with a general introduction and classification of the topic, followed by receptor pharmacology and mechanism of action, structure-activity relationship, classification and depolarizing blocking agents. Introduction of synthetic opioids analgesic. Successful treatment of pain is a challenging task that begins with careful attempts to assess the source and magnitude of the pain. The amount of pain experienced by the patient is often described in terms of a numeric visual analog scale, that is VAS, with word descriptors ranging from no pain, that is 0, to excruciating pain, that is 10. In severe pain, the administration of an opioid analgesic is usually considered a primary part of the overall management plan. Determining the route of administration, that is oral, parenteral, neuraxial, duration of drug action, ceiling effect, that is maximal intrinsic activity, duration of therapy, potential for unwanted side effects, and the patient's past experience with opioids should also be addressed. One of the principal errors made by physicians in this setting is a failure to adequately assess a patient's pain and to match its severity with an appropriate level of therapy. Just as important is the principle that following delivery of the therapeutic plan, its effectiveness must be re-evaluated and the plan modified if necessary if the response was excessive or inadequate. Use of opioid drugs in acute situations may be contrasted with their use in chronic pain management, where a multitude of other factors must be considered, including the development of tolerance to and physical dependence onto opioid analgesics. The term analgesia means without pain. Alleviation of pain is a major objective in medicine to increase the quality of life. Analgesia is the relief of pain without loss of consciousness, which is opposed to anesthesia. Morphine and morphine-like drugs, including synthetic opioids, differ from non-opioids in the following aspects. First, physical dependence, that is addiction, and tolerance is developed. Second, they have potential to abuse. Third, opioids act mainly within the central nervous system, while the non-opioid drugs act peripherally. Fourth, they are more powerful analgesics and do not reduce inflammation. Fifth, opioids undergo extensive first-pass metabolism, so preferred route of administration is parenteral. Molecular modification of morphine molecule resulted in new narcotic agonist and antagonist with fewer side effects. Opioids analgesics may be divided into the following classes. First, morphine and related alkaloids. Second, meperidine and congeners. Third, methadone and congeners. 4. Opioids receptor antagonist and partial antagonists. Receptor pharmacology and mechanism of action. Mu receptor. The mu receptor is characterized by its high affinity for morphine. It is a major receptor mediating actions of morphine and its congeners. Endogenous ligands for mu receptor, peptides called endomorphins 1 and 2, have recently been found in mammalian brain, produced biological effects ascribed to this receptor. Two subtypes of mu receptor have been proposed. Mu1 has higher affinity for morphine, mediates supraspinal analgesia and is selectively blocked by naloxonazine. Mu2 has lower affinity for morphine, mediates spinal analgesia, respiratory depression and constipating action. Kappa receptor. The kappa receptor is defined by its high affinity for ketocyclazosine and dynorphin A. This latter is considered to be its endogenous ligand. Two subtypes of kappa receptor, K1 and K3, are functionally important. Analgesia caused by kappa agonist is primarily spinal, that is through K1 receptor. Delta receptor. This receptor has high affinity for leucine or methionine enkephalins, which are its endogenous ligands. The delta-mediated analgesia is again mainly spinal, but the affective component of supraspinal analgesia appears to involve delta receptors because these receptors are present in limbic areas, also responsible for dependence and reinforcing actions. Table 1. Opioid receptor subtypes, endogenous opioid peptide affinity and some of their functions. Receptor subtypes, mu, functions, supraspinal and spinal analgesia, sedation, inhibition of respiration, slowed gastrointestinal transit, modulation of hormone and neurotransmitter release, endogenous opioid peptide affinity, endorphin greater than enkephalins greater than dynorphins. Receptor subtype, delta, functions, supraspinal and spinal analgesia, modulation of hormone and neurotransmitter release, endogenous opioid peptide affinity, enkephalins greater than endorphins and dynorphins. Receptor subtype kappa, functions, supraspinal and spinal analgesia, psychotomimetic effects, slowed gastrointestinal transit, endogenous opioid peptide affinity, dynorphins greater than endorphin and enkephalins. Mechanism of action. Opioid agonists produce analgesia by binding to specific G protein coupled receptors located primarily in brain and spinal cord regions involved in the transmission and modulation of pain. Receptor types. Three major classes of opioid receptors, that is mu, delta and kappa, have been identified in various nervous system sites and in tissues. Each of the three major receptors has now been cloned. Cellular actions. At the molecular level, opioid receptors couple to G proteins and through this interaction affect ion channel gating, modulate intracellular calcium disposition and change protein phosphorylation. The natural and derived opioids have two well-established direct actions on neurons. First, they close voltage-gated calcium channels on presynaptic nerve terminals and thereby reduce transmitter release. Second, they hyperpolarize and inhibit postsynaptic neurons by opening potassium channels. Explain the spinal sites of action. The mu, delta and kappa agonists reduce transmitter release from presynaptic terminals of nociceptive primary afferents. Mu agonists also hyperpolarize second-order pain transmission neurons by increasing potassium conductance, evoking an inhibitory postsynaptic potential. Synthetic opioid analgesics agents, that is drugs, meperidine and congeners, that is 4-phenylpiperidine analgesics. Meperidine is predominantly a mu receptor agonist and it exerts its chief pharmacological action on the CNS and the neural elements in the bowel. Meperidine is no longer recommended for the treatment of chronic pain because of concerns over metabolite toxicity. It should not be used for longer than 48 hours or in doses greater than 600 mg per day. Chemistry of meperidine and congeners, that is 4-phenylpiperidine analgesics. The spasmolytic properties of 4-phenylpiperidine derivative were being found due to their chemical relationship with the atropine. However, ethyl-methyl 4-phenylpiperidine 4-carboxylate was found to have anti-nociceptive properties. When R is substituted with different functional groups, then various compounds are formed as given in the table. Meperidine hydrochloride synthesis. When 2-phenylacetonitrile reacts with 2-chloro and 2-chloroethyl N-methyl ethanamine in the presence of sodium oxide, it gives ethyl 1-methyl 4-phenylpiperidine 4-carboxylate, that is meperidine hydrochloride. Pethidine was synthesized as an atropine substitute and has some actions like it. It is chemically unrelated to morphine. It interacts with opioid receptors and its action is blocked by naloxone. Important differences in comparison to morphine are dose to dose 1/10th in analgesic potency. However, analgesic efficacy approaches near to morphine and is greater than codeine. After intramuscular injection, the onset of action is more rapid but duration is shorter, that is 2 to 3 hours. It does not effectively suppress cough. Meperidine has significant antimuscarinic effects and negative inotropic action on the heart. The potential for producing seizures in number of patients due to receiving high doses of meperidine. Spasmodic action on smooth muscles is less marked. Meiosis, constipation and urinary retention are less prominent. It is equally sedative and euphoriant, has similar abuse potential. The degree of respiratory depression seen at equianalgesic doses is equivalent to morphine. Tachycardia, that is due to antimuscarinic action, occurs instead of bradycardia. It causes less histamine release and is safer in asthmatics. It has local anesthetic action and corneal anesthesia is seen after systemic doses. Absorption and metabolism. It is well absorbed oral. Parenteral activity ratio is high, that is 1/3 to 1/2. Meperidine is nearly completely metabolized in liver. The plasma half-life of pethidine is 2 to 3 hours. Acidification of urine increases excretion of unchanged pethidine. Fentanyl citrate. Pethidine congener, that is 80 to 100 times more potent than morphine both in analgesia and respiratory depression. In analgesic doses, it produces few cardiovascular effects and has little propensity to release histamine. Because of high lipid solubility, it enters brain rapidly and produces peak analgesia in 5 minutes after intravenous injection. The fentanyl subgroup includes sufentanil, L-fentanyl and remifentanil in addition to the parent compound fentanyl. These opioids differ mainly in their potency and biodisposition. Sufentanil is 5 to 7 times more potent than fentanyl. L-fentanyl is considerably less potent than fentanyl, acts more rapidly and has a markedly shorter duration of action. Remifentanil is metabolized very rapidly by blood and non-specific tissue esterases, making its pharmacokinetic and pharmacodynamic half-lives extremely short. Methadone. A synthetic opioid chemically dissimilar but pharmacologically very similar to morphine both in analgesia and respiratory depression. The most important feature of methadone is high oral parenteral activity ratio, that is 1:2, and its firm binding to tissue proteins. In single doses, it is only slightly more potent than morphine and has comparable duration of action, that is 4 to 6 hours on intramuscular injection, but it accumulates in tissues on repeated administration. It is metabolized in liver primarily by demethylation and cyclization. Metabolites are excreted in urine. Rifampin and phenytoin can cause withdrawal symptoms to appear in methadone. Methadone is a racemate, but its activity is mainly due to levomethadone. Endogenous opioid peptides. A number of endogenous opioid peptides having morphine-like actions are present in mammalian brain, pituitary, spinal cord and gastrointestinal tract. These are active in very small amounts. Their actions are blocked by naloxone and they bind with high affinity to the opioid receptors. Classification of endogenous opioid peptides. There are 3 distinct families of opioid peptides. Each is derived from a specific large precursor polypeptide. Endorphins. Beta endorphin, that is beta endorphin, having 31 amino acids, is the most important of the endorphins. It is derived from pro-opiomelanocortin, that is POMC, which also gives rise to gamma MSH, ACTH and 2 lipoproteins. Beta endorphin is primarily mu agonist, but also has delta action. Enkephalins. Methionine enkephalin and leucine enkephalin are the most important. Both are pentapeptides. The large precursor peptide proenkephalin has 4 methionine enkephalin and 1 leucine enkephalin residues. The two enkephalins have a slightly different spectrum of activity, while methionine enkephalin has equal affinity for mu and delta receptors. Dynorphins. Dynorphin A and B are 8 to 17 amino acid peptides derived from prodynorphin, which contains 3 leucine enkephalin residues. Dynorphins are more potent on kappa receptors but also activate mu and delta receptors. Significance of endogenous opioid peptides. The opioid peptides constitute an endogenous opioid system which normally modulates pain perception, mood, hedonic, that is pleasure related, and motor behavior, emesis, pituitary hormone release, and GIT motility. Beta endorphin injected directly into the brain is 20 to 40 times more potent analgesic than morphine. Its primary localization in hypothalamus and pituitary and its long half-life explain its neurohormone function, which modulates the release of other hormones. It decreases luteinizing hormone, follicle stimulating hormone release, and increases gonadotropin hormone and prolactin release. Opioid receptor antagonist. These agents are useful in the treatment of overdosage with opioids. Classification. Agonist antagonists, that is kappa analgesics. The agonist antagonists, that is agonist at one opioid receptor, antagonist at the another. For example, nalorphine, pentazocine, butorphanol. Partial or weak mu agonist plus kappa antagonist. Buprenorphine, which has low intrinsic activity. Opioids are analgesics of comparable efficacy to low doses of morphine but with a limited dose range. They cause low ceiling respiratory depression and have lower abuse potential. Pure antagonists. Example, naloxone, naltrexone, nalmefene. Nalorphine, that is 17-allyl 7,8-dihydro 4,5-alpha epoxy morphinin 3,6-alpha diol. Substitution of an allyl group on the nitrogen atom of opioids, example, N-allyl normorphine, generally reversed opioids action. Nalorphine possessed analgesic properties with less respiratory depression than morphine. Nalorphine is an antagonist at the omega receptor and an agonist at the kappa receptor. Nalorphine is not used clinically because of dysphoric and psychotomimetic effects. Pentazocine, that is 1,2,3,4,5,6 hexahydro 6,11 dimethyl 3,3-methyl 2-butenyl 2,6-methano 3-benzazocine 8-ol. It is the first agonist antagonist to be used as an analgesic. It has weak mu antagonist and more marked kappa agonist actions. The profile of action is similar to morphine. The analgesic and respiratory depressant activity of racemate is due to the LEVO isomer. Important differences are: first, analgesia caused by pentazocine is primarily spinal, that is kappa 1, and has a different character than that caused by morphine. Sedation and respiratory depression is 1/3 to half of morphine at lower doses and has a lower ceiling effect. Third, tachycardia and rise in BP are produced due to sympathetic stimulation. This may increase cardiac work, coronary ischemia, and myocardial infarction. Buprenorphine. It is a synthetic thibane congener. It is highly lipid soluble and mu analgesic activity is 25 times more potent than morphine. It has slower onset and longer duration of action. Sedation, vomiting, meiosis, and cardiovascular effects are similar to morphine, but constipation is less marked. Buprenorphine is indicated for long-lasting painful conditions requiring an opioid analgesic, for example, cancer pain. It has also been recommended for pre-medication, post-operative pain, in myocardial infarction, and in the treatment of morphine dependence. Buprenorphine is not suitable for use during labor because if respiratory depression occurs in the neonate, it cannot be effectively reversed by naloxone. Naloxone. It is N-allyl nor-oxomorphone and a competitive antagonist on all types of opioid receptors. It blocks mu receptor to much lower doses than those needed to block kappa or delta receptors. It is devoid of any kind of agonist activity even at high doses. No physical or psychological dependence or abstinence syndrome has been observed. Naloxone also blocks the action of endogenous opioid peptides. Naloxone is a drug of choice for morphine poisoning. Naltrexone. Naltrexone is an orally available opioid receptor antagonist that blocks the effects of exogenous and presumably endogenous opioids. It is chemically related to naloxone and is another pure opioid antagonist. It is more potent than naloxone. Naltrexone differs from naloxone in being orally active and having a long duration of action. Naltrexone, an inhibitor of opioid receptors, was the first drug approved by the FDA for treatment of alcohol dependence. Summary: the term analgesia means without pain. Alleviation of pain is a major objective in medicine to increase the quality of life. Analgesia is the relief of pain without loss of consciousness, which is opposed to anesthesia. Successful treatment of pain is a challenging task that begins with careful attempts to assess the source and magnitude of the pain. Dozens of combination products are available, and they also produce analgesia by binding to specific G-protein coupled receptors located primarily in brain and spinal cord and involved in the transmission and modulation of pain. Three major classes of opioid receptors, that is mu, delta and kappa, have been identified. Each of the three major receptors has now been cloned. A number of endogenous opioid peptides, that is endorphins, enkephalins, dynorphins, having morphine-like actions are present in mammalian brain, pituitary, spinal cord and GIT. These are active in very small amounts. Their action are blocked by naloxone and they bind with high affinity to the opioid receptors. Opioids antagonists are useful in the treatment of overdosage, poisoning and toxicity with opioids. With all these information, here we come to the end of today's lecture. Do keep in mind what we have discussed today. This is time for your self-study. If you want to learn more for enhancing your knowledge, you may log on to our website www.cec.nic.in for MCQ, quiz and LORs. Till then, keep studying. Goodbye.